This is Dr. Yoshifumi Fujita from Tokushima, Japan.
Yeah.
And he's here with us today. He operates a large clinic there and has, how long have you been in practice over there?
20 years.
20 years, okay.
Yeah.
Can you tell us a little bit about your clinic and what
clinic?
you do? Yes.
We have 6 doctors and 5 doctors perform cataract surgery. And the number of cataract surgery is more than almost 3,000 cases.
So, how has cataract surgery evolved over the past 20 years? What are the biggest differences that you've seen over
The procedure is same in these days.
Mm-hmm.
And new doctor came to my clinic 1 year ago.
Mm-hmm.
So I have taught the technique to this new doctor.
Mm-hmm.
When he came, he didn't do cataract surgery.
Mm-hmm.
But in a year, he became a good surgeon. And procedure is 2.4 millimeter clear cornea incision.
Mm-hmm.
And I usually use Centurion vision system for phaco.
Mm-hmm.
And premium IOL, presbyopia correcting IOL is 50% of
Mm-hmm.
all cases, and toric IOL is also 15% of all cases. And the procedure has not changed in these days.
Mm-hmm.
The same procedure, but it's very effective, and I think it's good.
Have your outcomes improved over time?
Of course, the outcome is very good.
Mm-hmm.
I usually use monofocal IOL, but maybe 75% is monofocal. Post-op 1 day visual acuity is very good, so I'm very satisfied with that outcome.
Mm-hmm. Okay. I understand that you've designed a number of instruments through your career.
Mm-hmm.
The ASRCS forceps that are being manufactured by ASRCS. Can you tell me how you got involved in that and why you got involved in designing or changing the design of an instrument?
My instrument in ASRCS is Inamura and Fujita eye forceps.
Mm-hmm.
And that is to make CCC very easily.
Mm-hmm.
And this instrument is very stubborn.
Mm-hmm.
So, and the size is very nicely modeled.
Mm-hmm.
So I think this one is very good. I believe.
Right. What was it that made you decide you wanted a new instrument? Was there some issue that you were having or some opportunity to improve that you saw?
3 days a week, I perform cataract surgery.
Mm-hmm.
And the procedure is the same, I told you.
Mm-hmm.
But something is, I think I would like to be more easily. I'd like to do the surgery more easily or more effectively. So I like to change. I like to change the original ASCO forceps. So that is why I suggested the agent in ASCO to change the model a little bit.
And what was the nature of the change? What did you
The stubbornness,
to make it stiffer?
stubbornness, yeah.
Right. So that it
Yeah.
so that
Because,
there's less flex in it.
So that's right.
Okay.
Yeah.
Yeah. Okay. So that helps you have a little bit better control.
Yes,
then.
I think so.
Okay, that's great. How long ago was that?
Maybe 10 years ago.
Okay. Do you use the pre-chopping technique?
No, because my favorite is the fake chop technique, and of course I know Dr. Akahoshi. He's my good friend, and he invented his very nice technique, fake pre-chop. But I prefer fake chop technique because I don't think I don't change the style
Right,
from
right.
fake chop to
Pre-chop.
pre-chop technique.
Right, right. Yeah, so it's something that you're comfortable with.
Yes,
and
fake chop technique. Yeah.
obviously very skilled at. Do you find that it's, is it a challenge to teach new surgeons how to do it?
Pre-chop technique is maybe it's simple, and but also I started from fake chop technique, so
Right, right.
so
So
I
you're,
don't have the mind to change the
Right,
technique.
right.
But and I told you that I also teach young surgeon how to disassemble the nucleus. I think fake chop technique is the best one.
Okay.
I recommend.
all right. You mentioned that you implant quite a few toric lenses.
Yes, yes.
How do you do your marking? What
Marking. I use variant, Alcon variant technique. And before using the variant, I usually mark the patient at the outpatient and take the patient to the operation room and then check the patient mark with toric marking by ASRCS. But now I use variant, so I don't need to use that astigmatism marker.
Right, right. So, okay. How are your outcomes with the toric? Do you find that? Did you write a paper about this? About the
Toric
About-
IOL?
toric rotation? Or maybe I'm
Right,
thinking of
right,
something.
yeah,
Okay.
you know that, yeah.
Right.
And Dr. Oshika, he's my also friend, and we checked the rotation among 3 IOL types. And the result is Alcon toric is best. Less torsion,
Right.
torsion.
Resist.
Compare with Hoya and AMO, toric IOL.
And that was not too long ago that was published.
Pardon?
How long ago was that?
Yeah,
Just
a year ago.
a couple of years, yeah, a year ago. Okay. Well, that's interesting. Have you done other research? You do other research in your practice?
Now I do the premium IOL results, and I usually use Technic Symphony, and there are 3 kind of insertion. Symphony, both lengths, both sides, and one is far and far, one is far and a little myopia. That is called micromonovision.
Right, right.
And one is far and symphony, and the other multifocal IOL. I usually use ZLB. ZLB, so the target is 40 centimeter. So I'm now trying to find which one is better. I think micromonovision may be the best one.
Right.
I think so.
to use a micro monovision with a multifocal IOL?
Right. Yeah.
Okay.
Symphony.
Right. Okay. So that's the one that has the extended depth of vision.
Yes.
Right.
That's right.
So then with the micro, then you get a little bit better
Yeah. That's
nearer
right.
in the one eye. Yeah. Okay. Well, that's interesting. What do you find what's the advantage of that over the trifocals or bifocals?
Trifocal IOL. Yeah. In Japan, the panoptics is not sold. It's not delivered in Japan. And so I usually use fine vision trifocal IOL. And the visual acuity at far, intermediate, and near, fine vision is very nice result. So the patient eagerly want to do the better lens or best lens. I usually choose fine vision for the patient.
How do you decide? How do you make the decision of what lens to use or who's a good
It
candidate?
depends on the patient. Patient wants to see every distance. I usually use fine vision. But the patient doesn't want so much. And the fine vision is very expensive in Japan. And in Japan, there is the system of self-insurance. So
Right.
self-insurance company can give the patient the money. So patient doesn't pay out of pocket. So and if the patient doesn't need so much, I usually use self-insurance IOL.
Right.
That is Symphony, and that is Technics Multifocal. That is Restore. But fine vision is not.
That doesn't reimburse enough to pay for that. Yeah.
Yes, that's right.
Right. So then, are people allowed to pay the extra, or if they use, do they just pay the additional money then to get it? Yeah. So are people pretty price sensitive about that, or are they very sensitive to the price
Yes,
of
that's
it?
right. Yeah,
Yeah.
of course. Patient and doctor also.
Yeah.
Yeah.
You don't want to burden someone, I guess. Yeah.
That's
Oh,
right.
that's great. That's great. So, are there enough surgeons in your area to meet the need that you're seeing in the community?
My town is very small, and usual doctor do perform cataract surgery 300 to 400 a year.
Yeah.
But I do almost 3,000 cases. But in the city, there is no problem for eye surgeon and patient. But in the rural area, there is not so much eye doctors in Japan. So that is a problem. So it's a very difficult problem.
Do people travel to your clinic
right.
from the surrounding rural areas? Do you have any other doctors that you work with who are out in the field there? Or
Yeah, that's right.
yeah. So would those be just regular doctors or not necessarily ophthalmologists?
That's right.
Yeah. So they would refer them into you. Yeah. So do you feel like there's enough capacity in the system that you're able to provide enough services to meet the increasing need?
I don't think so. The cataract surgeon is not enough in Japan. So aging is a problem in Japan, and there are many cataract patients. There will be many cataract patients. So we have to teach young surgeon to do cataract surgery more excellently. So that is the problem. The education is the most important thing in Japan.
So do you have, you train someone yourself in your clinic. Do you work with any residency programs or in any formal education programs?
There is one university in Tokushima that is called Tokushima University School of Medicine. Students, medical students come to and look at my clinic, the operation, and those patients are very interested in cataract surgery because it's very fine and it's very short time and excellent result. So I usually talk the students, please become eye doctor in the future. So
have you had many successes with that?
That's right.
Oh, that's great. Yeah. That's great. I'm sure you're very convincing. What do you see as the biggest challenges that are facing ophthalmology? You have the aging. You have, I'm sure a lot of the doctors are aging too, so a lot of them are retiring. How do you see the supply problem being addressed?
Because I'm 65 years old, and I have decreased my operation number, and we in Japan there are many same age,
right. It's a cohort.
Doctors. There are many. So we think about when we abandon the cataract surgery. But I think the operation microscope is very good, and fake machine is very good, and good instruments help us to extend our challenging time.
Right.
Yeah. So I like to continue my cataract surgery over 70 years.
Okay. So part of your plan is just to continue to practice. Yeah. What role do you see for working with industry or working with people like ASRCS to develop tools that make the procedure easier or quicker or more efficient, and efficient not just in terms of speed but in terms of providing a good outcome that prevents complications and so on?
I think the most important thing is talk each other. And ASCO give us good information about cataract surgery. That is very important for us. And I like to contact after delivering information. So the relationship with doctors, between doctors and the company, the most important thing is connection. And you know that in Japan there is prohibited to have dinner with company person. You know that. But actually, we should talk more and more. That is for the patient. Because we like to know more about information about the instrument or machine, everything around cataract surgery. But we don't have so many chance to talk because doctor is very busy to talk to each other. So the most important thing is connection, relationship.
Is there anything that you would like to say that we haven't discussed or that you'd like to add or emphasize about?
Yeah, it's my great pleasure to talk with you.
And you as
And,
well. Great. Well,
thank you
thank you very much.
Thank you so much.
I really appreciate it, and I admire your work.
Thank you so much for your assistance.
Generally, and you in particular.